This is a FIGO conference presentation. FIGO is World Congress of Gynecology and Obstetrics, holding in Australia in between October 21 and 28, 2021. There will be a presentation made by Dr. Eleje, who is the associate professor with Nnamdi Azikiwe University Teaching Hospital, Nnamdi Azikiwe University, Awka, Nigeria, and a consultant with the Nnamdi Azikiwe University Teaching Hospital, Nnewi, which is a research that is multi-centered, as you can see, titled Efficacy and Safety of Mojeaga in Combination with Conventional Oral Iron Therapy for Correcting Anemia in Gynecology and Obstetric Population. It is a pilot randomized clinical trial which is ongoing, and we are now presenting the pilot study in the forthcoming FIGO conference holding in Australia, but it's a virtual conference. There is no conflict of interest. Anemia in women is a major public health burden worldwide, particularly in low and middle income countries. Iron deficiency anemia during pregnancy is associated with an increased risk of preterm birth, low birth weight, fetal growth restriction, and increased neonatal and maternal mortality. Additionally, iron deficiency anemia may predispose to postpartum iron deficiency anemia, peripartum blood transfusion, infections, and precipitate heart failure. And therefore, we need to be very careful when managing those such patients so as to correct the anemia before they deliver, so that to avert these dangers. So iron deficiency anemia, or iron when administered intravenously or blood transfusion, is increasingly being recommended in obstetric and gynecology practice in cases of severe anemia. But despite this increased recommendation, the intravenous drug administration have been infrequently utilized in clinical practice due to undesirable adverse reactions, including severe allergic reactions and anaphylaxis. Again, blood transfusion is not without complications, and some religious groups object to blood transfusion, such as Jehovah's Witness denominations. Even those who are not witnesses today are rejecting blood transfusions, and therefore there is need for us to have a study on any available alternatives to blood transfusion, especially in gynecology and obstetric practice. Hence the need for this study. Mojeaga is produced by Mojeaga International Ventures Limited, Nigeria. Is a natural preparation containing a triplex of Arconia penicetum and sorghum extracts. It contains free organic oral iron preparation, among other nutrients, that allows co-administration of conventional hematinics or other iron preparation. Meaning that if a patient is taking Mojeaga, he or she can also take other preparation, other hematinics, without any drug-drug interactions. The penicetum extract and sorghum extract in Mojeaga are excellent sources of iron, potassium, flavonoids, and other phytonutrients. And therefore, Mojeaga may work by promoting healthy metabolic processes because it contains high levels of B group vitamin B complexes. It also works by effectively mopping up the free radicals and reactive oxygen species, and quickly reverse the lipid peroxidation and cellular damages. In one previous study, it indicated that Mojeaga increases levels of packed cell volume and hemoglobin. It is a case report that was published by Eleje et al. In 2018 in Hong Kong Journal of Obstetrics and Gynecology. It also noted that Mojeaga contains antioxidants and natural minerals, and it has strong anti-inflammatory property. and enhances general body metabolism. It also builds immune system, and it is high in natural iron. And now for even those who have low immunity, like those who are suffering from HIV/AIDS, may also benefit from this drug. But for this presentation, we are focusing on anemia, how gynecology patients and obstetric patients, those who are pregnant, can benefit from this drug. So to our knowledge, there is no prior randomized control trial on the effectiveness of Mojeaga when co-administered with conventional oral iron therapy schedule for correction of anemia or in obstetric and gynecology practice. So this is the first study to date, first randomized trial on this product. So the objective of this study, this randomized trial, is to determine the mean hematocrit level, that is packed cell volume, proportion of disappearance of anemic symptoms, and proportion of maternal and fetal adverse events following administration of this drug in those women or gynecological patients or pregnant women having iron deficiency anemia. So the target comparison is among obstetric and gynecology patients diagnosed with anemia who are receiving combined Mojeaga and conventional iron therapy, compared with those who are on conventional iron therapy alone. In other words, those who are involved in this study, or who are involved in this study, are those who are receiving standard of care alone, compared with those who are also receiving standard of care plus Mojeaga syrup. So the Mojeaga is the drug, the testing drug here, or the study drug here. So those in both arms, no matter the arm you belong, you receive standard of care. But the only difference now, one group will receive Mojeaga. So we're looking at those groups that receive Mojeaga. Do they perform better in terms of anemia resolving, or in terms of packed cell volume, blood building, or in terms of adverse events? These are what were investigated in this study. So as I said earlier, it is a randomized control open label multicenter study. It was on consecutive obstetric and gynecology women with signs or symptoms of anemia. The study period was between 2019 to May 2021. The study actually is still ongoing, but we're only presenting the pilot study. The study took place in Nnamdi Azikiwe University Teaching Hospital, Nnewi, Chukwuemeka Odumegwu Ojukwu University Teaching Hospital, Awka, and Esut Teaching Hospital, Park Lane, Enugu. All these three hospitals, they are tertiary hospitals that are located in southeast Nigeria. The eligibility criteria included consenting pregnant and non-pregnant women, and pregnant women who are at a gestational age of less than 13 weeks were excluded. So those who are in the first trimester were excluded. So we only included those in the second trimester and above. So the intervention, those the participants were randomized to either Mojeaga 50 ml administered 3 times daily, plus the standard of care, which was given, maybe they might be on Astifa alone 2 times daily for 2 weeks, or those who received standard of care, which is Astifa, standard of care that contains only oral iron therapy, and that here is Astifa to those standard of care. So at recruitment, they were tested for hematocrit at baseline. Then after 2 weeks, those hematocrit level were also checked to check whether there is a change in the hematocrit or packed cell volume following administration of this drug, which is taken for 2 weeks. So the primary outcome measures included mean rise in hematocrit level, the incidence of normal hematocrit level, which is post-therapy. What the secondary outcome included the incidence of disappearance of any previously existing anemic symptoms and the incidence of any adverse events. So all the laboratory parameters were carried out by the senior laboratory scientists in the hospitals concerned. The analysis was by intention to treat. And as I said earlier on, this trial were registered with NAFDAC. The NAFDAC number is NAFDER/LAG/V&CT/Mojeaga 2020. This is the NAFDAC number, NAFDAC approval, the trial. Again, the trial was also registered with the WHO site located in the Pan-African Clinical Trial Registry. This is the site, www.panafricaclinicaltrial.samrc.ac.za, and this is the Pan-African Clinical Trial Registry number. So it is an open site which all these trials were registered and fully successfully registered online and is available publicly. So what was the result from this pilot study? The 41 participants was randomized. They were randomized into 21 were assigned to receive Mojeaga and standard of care, while 20 received standard of care alone. 36 were pregnant women out of these 41 participants. And out of these 36 pregnant women, those in Mojeaga group were 18, and those in the standard of care group was also 18. And the mean gestational age at recruitment for those in Mojeaga group was 29.7 weeks, while that of standard of care was 28.8 plus or minus 3.0 weeks. So far, at the time of this analysis, 41 participants completed their treatment and were included for analysis. So the results show that the baseline characteristics were not significantly different between the two groups, such that the mean age, body weight, height, and the pre-therapy hematocrit were all similar. There were no significant difference between the two groups, as you can see on the slide. Then what about 2 weeks therapy? The mean rise in hematocrit values at 2 weeks follow-up from baseline was significantly higher in the Mojeaga group. As you can see, the rise is for the Mojeaga group was 9.19%, compared with 5.70% for those who received standard of care. So the p-value was 0.008, which was statistically significant. Additionally, the mean hematocrit values at 2 weeks follow-up was what we have reported. So values was significantly higher in Mojeaga group for the actual hematocrit number value. Remember, the first one I presented was the mean rise in hematocrit from baseline, what it was before the recruitment. But here now is the overall in terms of hematocrit value. For the Mojeaga group is 30.05%, while that in the standard of care group is 27.90%, which is also statistically significant from the slide. So all these things are favoring Mojeaga. Now, for symptoms improvement, Mojeaga was associated with greater improvement in dizziness scores, although there was no difference in tolerability and outcome in other clinical parameters between the two groups. In terms of adverse events, there is no difference in renal and hepatic function test parameter, because we also looked at the liver and renal functions before and after therapy to check whether this drug has effect on liver and kidneys, and there was no difference in the renal and hepatic function parameters. So no serious adverse events were noted in either group, and there was no recorded maternal or fetal death for those pregnant women who received the drug. So for the strength and limitation of the study could be that this is the first randomized control trial on Mojeaga anywhere in the world. So it's a pilot study. Sample size is low or small. As you can see, we have only recruited 41 at the time of this report, which were presented in the FIGO conference holding in Australia. But however, the trial is still ongoing, but we are presenting the preliminary report in this conference. So we can conclude that the use of Mojeaga for correction of anemia is effective and very promising and appears safe in obstetric and gynecology practice. More information on efficacy and safety of the Mojeaga could be obtained from studies with larger population of women. This will be clearer at the conclusion of the ongoing trial. So thank you for listening, and these are my references. The first reference here is the first paper which the report which Eleger et al. Now published in Hong Kong Journal of Obstetrics and Gynecology in 2018, titled Successful Management of Severe Anemia Without Blood Transfusion in Pregnancy and Puerperum using Mojeaga at Adjunct Therapy, a report of 2 cases. And we can also see other references in support of this. Thank you for listening. Thank you all. We'll meet again.